A nucleus drop during phacoemulsification is perhaps one of the most devastating complications that we may face while performing a phaco. There has to be an understanding of how we should approach the case once we've had a nucleus drop prior to handing the case over to our vitreoretinal colleagues. I'd like to now discuss a systematic approach in how we should manage the case when we have a patient with a nucleus drop. Let's now move to watching the surgery. One of my students, while performing a phacoemulsification, ended up with a nucleus drop whilst performing the nucleus disassembly and emulsification. When I took over the case, this is what I saw. There was a stable capsular excess, there was residual cortex, and I could see a linear tear between the 11 and the 5 o'clock position. On looking more closely, I could see a fairly large nucleus fragment in the vitreous cavity. With a rent this large and a nucleus fragment in the vitreous cavity, I choose to now introduce some triamcinolone acetonide in the anterior chamber with a view to ascertain the presence or the absence of disturbed vitreous. And in a few moments after injecting the triamcinolone in the anterior chamber, it is then washed out. Upon washing out the triamcinolone, as you can see, it's clearly obvious that there is a significant disturbance of vitreous in the anterior chamber. The stained vitreous can also be seen prolapsing through the main incision. The paracentesis incisions are suitably enlarged to allow for the entry of a 20-gauge cutter, after which we start with the anterior vitrectomy. At the outset, the vitreous that's prolapsed out of the incisions is cut, after which I introduce the irrigation to the right side port incision, whilst the 20-gauge cutter is introduced into the anterior chamber and starts to cut the vitreous. The vitreous is first cut from just within the incisions and then from the anterior chamber. Having cleared this, we then move to cut the vitreous in the area of the pupillary plane and finally in the area of the PCR. It's important to always remember that there should be no attempt to moving the vitrectomy cutter posterior to the area of the rent, and certainly not going to try and fish out the fragment that has fallen behind. Having completed the limited anterior vitrectomy, we now go in the IA cut mode with a view of removing the cortex. You will note how the irrigation probe maintains the anterior chamber and stabilizes the globe, whilst the vitrectomy cutter now works like an aspiration cannula, drawing out the cortex from under the rhexis and then aspirating it. Let's now watch the rest of the cortex wash using the IA cut mode of the vitrectomy. Notice how as the cortex is being drawn out, you can see the fragment in the posterior segment floating up slightly anteriorly. Now, having completed the removal of the cortex on the right side, the instruments are swapped over and the rest of the cortex is similarly removed. The two very important things that we need to avoid during this step is one, accidentally holding on to and pulling on the vitreous, and second, accidentally damaging the anterior capsule. You can see how with care and caution, we've been able to completely remove the entire cortex from behind the anterior capsular rim without any accidental loss of cortex to the vitreous. At this point, you can see the large rent in the posterior capsule. We've now understood that when faced with a nucleus drop, step 1 is to introduce some triamcinolone to look for any disturbed vitreous. Should you find it, you need to perform a limited anterior vitrectomy wherein the entire disturbed vitreous needs to be cut, after which in the IA cut mode, the cortex needs to be carefully removed without compromising the anterior capsule. Finally, having achieved this, we now move to implanting the 3-piece IOL in the ciliary sulcus, for which you can see we've now taken a 3.2mm keratome and enlarged the main incision to about 3.4 to 3.6 millimeters. Let's now understand the loading and the implantation of the 3-piece IOL. This is the 3-piece IOL which comes preloaded. Some viscoelastic is introduced above it and within the nozzle of the cartridge, after which, after pushing the optic down, the cartridge is snapped shut. Then, under direct visualization under the microscope, the orientation of the leading haptic in the cartridge is carefully noted. We now move to the implantation of the 3-piece IOL in the ciliary sulcus. Counter pressure and support to the optic are afforded by the Sinskey hook introduced to the right side port incision. I'd like you to note how the tip of the cartridge is introduced well within the anterior chamber so as to guide the leading haptic into its position in the ciliary sulcus, after which the rest of the optic is injected in the anterior chamber and the trailing haptic, as you can see, remains outside the eye. At this point, some more viscoelastic is introduced into the eye, after which a Coughlin hook hitched to the trailing optic haptic junction aids in introducing the trailing haptic in its correct position in the ciliary sulcus. Let's now watch the posterior optic capture. After achieving the correct orientation of the haptics, each edge of the optic is dipped behind the capsular excess edge, as you can see, with the resultant posterior optic capture. Having achieved the desired IOL placement, that is the haptics in the ciliary sulcus, with a posterior optic capture, with care and caution and ensuring that we don't lose the posterior optic capture, the excessive viscoelastic is removed from the anterior chamber. Having completed the visco wash, while still maintaining the irrigation in the eye, the left paracentesis incision and the main incision are hydrated. And finally, the irrigation is removed from the eye and the right paracentesis incision is also hydrated. This is the way in which an anterior segment surgeon completes the management of the anterior vitrectomy, the removal of the cortex, and the optimal placement of a 3-piece IOL in the ciliary sulcus with a posterior optic capture. And having done so, one confirms the absence of any vitreous in the anterior chamber, and finally this is the last step wherein the main incision, which is a good 3.6mm incision, is sutured with the tenor nylon suture, the suture not buried, and it is only at this point we now hand over the case to the posterior segment surgeons to take over for the pars plana vitrectomy with fragment removal. With this we come to the end of the video tutorial. A nucleus drop can also happen and often does, even in the most experienced of hands. This, according to me, is the systematic approach of how an anterior segment surgeon manages the disturbed vitreous, the residual cortex, achieves an optimal pseudophakia, sutures the wound prior to handing the case to our vitreoretinal colleagues for the fragment removal. I do hope you found this video tutorial useful. Thank you.